Assalamu alaikum. Back to another IMANA education webinar tonight. And tonight's topic is, should we let children play contact sports, or does the risk of brain injury outweigh the benefits? Tonight's speaker is Dr. Uzma Samadani. Her family and her are longtime supporters of IMANA. Before she gets started on this really interesting topic tonight, a topic that we haven't spoken about in the past, I would like to tell you a little bit more about her. Dr. Samadani, she's an associate professor in the Department of Neurosurgery at the University of Minnesota, with graduate faculty appointments in neuroscience and bioinformatics and computational biology. She is also an attending neurosurgeon at the Minneapolis Veterans Administration Medical Center, and founder of the neurodiagnostic startup Oculogica Inc., which recently obtained FDA marketing authorization for aid in the diagnosis of concussion. Dr. Samadani is heavily involved in research specific to brain injury. I hope that she'll highlight some of her work tonight. She has also spoken at a number of events, including TEDMed, and has published more than 60 peer-reviewed scientific papers. Dr. Samadani is also served as an unaffiliated neurotrauma consultant to the National Football League from 2015 to 2018. Very interesting. And Dr. Samadani, we thank you so much for making the time to share your expertise tonight. And please get started whenever you're ready.
Well, thank you, Dr. Khan, for inviting me. It's absolutely my privilege to have this opportunity to talk to everybody. I tried to pick a topic that is relevant to not just physicians, but to everybody who has a kid who comes to them and says, hey, I want to play football, or I want to play hockey, or I want to play soccer. And, you sort of have to say, well, what does the evidence say? Should I make this decision or not? And what I'm going to present is a modified version of a talk I gave earlier at the Congress of Neurosurgery meeting, where I was asked to debate this topic against Jamie Ullman, who is the current or prior chair of the neurotrauma section. So, obviously there's some technicality to these slides, but what I would like to do is, if people have questions, please use the chat, or you can email me, or you can reach out to me on Twitter. I'm at Dr. Samadani, and we can always continue the discussion. So I'm really excited by this opportunity. Thank you for inviting me, and let's get started. So the question is should you let your child play contact sports? These are my disclosures. So I have funding from a number of different collaborators and organizations. I also have, as you mentioned already, some intellectual property, and we have a startup that is related to assessment of concussion and dementia after brain injury. So let's start with this slide. This is participation change by sport over time. And what we have seen is that over a 5-year period, the number of children participating in sports has dropped quite dramatically. And at this point in time, in 2019, for example, only about 17% of high school seniors still did 1 hour of exercise per day. The average age at which children stop participating in sports in general is between 11 and 13. Because what happens at that age is sports become very competitive. And if a child does not feel that they've mastered a sport, often they decide that they don't want to participate at all. And so that's what's happening with the American youth population. People are worried, they're wondering, well, if my kid plays football or something like this, are they going to end up, getting injured? Are they going to end up dead? Well, let's start with very clear statistics. What are the causes of death for children ages 10 to 14? Overwhelmingly, it's cars, suicide, and homicide. And sadly, suicide is the fastest rising cause of death, particularly in adolescent girls ages 11 to 14, but in all populations, including minority populations. So obviously, mental health is incredibly important for children and for youth. And so that's something that we're going to talk about in future slides. But this is just something to keep in mind, sort of on the background of, is contact sports or any sport in general a major cause of death for children? And the answer is, of course not. It's the other causes. Do sports cause death? Yes, they can. Riding in a car is about 25 deaths per million population. Suicide is about 25 deaths per million population every year. Equestrian, so horseback riding, is one of the most dangerous sports at 20 deaths per million. Biking, snowboarding, skateboarding, skiing, all of the speed sports, or what you would call the helmet sports, are about 15 deaths per million. And that tends to be things like, people colliding with biking, it's colliding with cars or pavement. With snowboarding and skiing, it's colliding with trees or other people. With skateboarding, again, colliding with traffic. So those are all very dangerous sports. Regular playground play is about 10 deaths per million. Football is about 6 deaths per million, so the number drops. And then swimming is one of the highest risk sports because it's 140 pediatric deaths per year. The denominator is confounded because some of those deaths are not actually due to swimming per se, but rather to a boating accident or to other, drowning type accidents. So obviously there are many different causes of death, and sports are among them. The other thing that people really worry about when it comes to sports, obviously, and the reason that we're having this discussion at all, is a brain injury. So this is one of the most rigorous studies ever performed. It was 109,000 Swedish children or Swedish adolescents under age 25 with traumatic brain injury, and they were compared to their siblings. And over time, these people who sustained a brain injury had an increased risk for pension disability, psychiatric hospitalization, and premature death. And the severity and the number of injuries correlated with the outcome in terms of severity. Suicide risk is increased after concussion. This is a large Canadian study, and what it demonstrated was that among 235,000 patients followed for 9 years, the suicide risk was increased from about 12 per 100,000 to 31 per 100,000. So it goes up about threefold after a brain injury. And the interesting thing is that it seems that if you get a brain injury on the weekend, it's worse than getting a brain injury on the weekday. And that may be a function of the fact that weekday brain injuries are more likely to have occurred at work. And therefore, they were treated from an occupational perspective, whereas weekend brain injuries were more likely to have occurred during leisure time, and therefore they were more likely to be less treated, less aggressively treated, and possibly ignored. So treating brain injury may actually play a role in the outcomes. So let's talk about football. So this is suicide mortality among retired National Football League players who played for 5 or more seasons. Among players retired since 1987, the suicide rate was 6.1 per 100,000. Since 2005, it was 12.5 per 100,000. And the average American man since 2014 is 20.1 per 100,000. So suicide is less common in NFL players than in the general population. Since 1987, NFL players are 70% less likely to commit suicide than the general population. So this is sort of a surprising fact for most people. The irony for those of us who are physicians on this call is that physicians actually have a higher suicide rate than NFL players. And actually for female physicians, it's about 38 per 100,000, which is close to twice the average for all American men. But even for male physicians, it's higher than the general American population. So we think of playing football as a risk factor for developing, suicidality, because we know that, it should be intuitive, right? Football causes brain injury causes suicide. But yet we see here from this data that football doesn't actually increase your suicide risk. So if football were a drug that was taken daily and we assess the standardized mortality ratio, which is the increase or decrease in mortality of a study cohort with respect to the general population, it reduces standardized mortality measured 30 years later by half, saving 296 lives at the cost of 17 deaths. This suggests to me that we don't really understand whether the risks of brain injury associated with playing football outweigh the benefits of sport participation for any given population. So let's dig into this a little further. Let's look first at the NCAA data. So the NFL data is only males. The NCAA data is males and females. So for males and females, the general population suicide rate is 12.6 per 100,000. For non-college students, it's 12 per 100,000. For college students, it drops to 7.5 per 100,000. athletes have a much, much lower suicide rate than general population. They're 0.93 per 100,000. And it's higher in football because that's a male-only sport, so it tends to go up, and it's 2.25 per 100,000. This is a 9-year study with more than almost 4 million participant seasons. So we can see that participating in sports in general is very, very protective for mental health. So now we've talked about the NFL level, we've talked about the NCAA level. What about at the youth level? What about children? So this is children ages 6 to 17 compared to the number of suicides in the total US population. And what we see is that the number of suicides has risen as the number of people participating in sports has gone down. Is there a relationship? Well, that's a good question. What we do know is that an increase in sports participation grades 7 to 12 leads to a decrease in depression by 25%, and suicidal ideation decreases by 12% with an increase in sports participation. So generally speaking, participating in sports is better for you than not participating in sports when it comes to a mental health perspective. So what's the other thing that people worry about? If you're not worried about death and you're not worried about suicide, well, what's the biggest thing that people worry about? And the actual biggest thing that people worry about when they talk about, should you let your kid play contact sports, is dementia. So let's talk about the relationship between brain injury and dementia. 1/3 of Americans have had a concussion in their lifetime. 2/3 of those concussions are in men. In males, in boys and men. Dementia occurs in 63.5 per 1,000 persons in the United States. It's twice as common in women. Approximately 5 million Americans have Alzheimer's. There's no reliable diagnostic, and it has an unknown cause. The most common types of dementia, vascular dementia, frontotemporal dementia, normal pressure hydrocephalus, all have variable etiology. Vascular dementia is thought to be most closely related to high blood pressure, diabetes, obesity. Those are your reversible risk factors for dementia. So what are the risk factors for dementia? This is from a Lancet review. The big ones: high blood pressure, diabetes, sedentary lifestyle, high fat diet, obesity, hearing loss, depression, smoking, poor education, particularly in women. And brain injury does show up on the list, particularly in men, especially if over age 65, or moderate to severe brain injury if over age 55. And decreased social contact is also a risk factor for dementia. So these are your risk factors for dementia. So what we have to do now is we sort of have to balance, we have to understand, does your risk for brain injury from sport overwhelm your risk for, reaping the benefits of sport? And that's really what we're wondering. Here's more data looking at the association between a single brain injury and mild cognitive impairment, Alzheimer's, or other types of dementia. This is 4,265 older adults followed for 45,000 years. And what they found was that there was no relationship in this particular study because this study included both men and women. However, if you break it down and you look only at men, there is a relationship. There's a 1.9-fold increased risk for dementia associated with the brain injury when is particularly in men who sustain a brain injury without loss of consciousness. A brain injury with loss of consciousness did not show a significant association, and nor was there a significant association in female participants in this study. So then what's all the talk about? Like, why are people reluctant to put their kid in sports? I guess it's probably because of this. It's because of chronic traumatic encephalopathy, which is sort of the dementia pugilistica, or the chronic effects of neurotrauma. This was first discovered in 1928. It was published in JAMA, found in 17% of living professional boxers. So the original CTE was a clinical diagnosis, not a pathological diagnosis. It was described in living people. It was named in 1969. It was characterized by motor deficits and dementia, and the pathology was described in the 1960s and 1970s at Queen Square in England. Many years later, in the 2000s, Bennett Omalu and Anne McKee's group presented new definitions for CTE. These were published in separate papers in Neurosurgery in 2005 and in a pathology journal in 2009. And basically, these two papers did a lot to sort of rock what people thought about, the understanding of post-traumatic encephalopathy. The British then compared the pathology of this particular phenomenon to the previously described phenomenon in the English literature. And they, to put it bluntly, were not amused. They said CTE as defined in America is not a neurological entity, but a cultural specific social phenomenon. And there was an editorial in the British Medical Journal. And then the Canadians responded with, well, we're not seeing it in our football players. So there was obviously some discussion around this. And there were papers published saying, is chronic traumatic encephalopathy a real disease? Does it have a unique neuropsychiatric profile? And this paper published in 2017 says, our review of the literature indicates that insufficient evidence currently exists to suggest a distinct neuropsychiatric profile for CTE. So you've got this problem. You've got, people having, neurologic dysfunction after playing football for years. And, clearly there's something going on. So the NIH steps in and they say, we're going to define this. We're going to establish what CTE is. And they held a consensus meeting. It was the first NINDS NIBIB consensus meeting to define the neuropathologic criteria for the diagnosis of CTE. And they described 4 types, and they noted that it could be asymptomatic. And the pathognomic lesion was phosphorylated tau, which is a protein that forms the structure of neurons. It becomes phosphorylated, it aggregates around small vessels in an irregular pattern at the depths of the cortical sulci. And that was the definition of CTE as established in 2016. The problem is that it was also seen in young and middle-aged people who did not go on to develop neurodegenerative problems. So only a subset of subjects with neurodegenerative changes early in life progress to a symptomatic disease with aging. And there are clearly yet unknown modifying factors that are influencing the progression. So the finding of hyperphosphorylated tau was not pathognomic for the clinical syndrome of dementia and motor disorders. This is from a paper published by Lily Naz-Hazrati in her group in 2019. And basically what this paper suggested was that this is a Venn diagram of 38 individuals with a history of mild TBI. And the ones who had no DNA damage had no clinical symptoms. The ones who had particular patterns of inability to repair DNA were more likely to have CTE or other neurodegenerative pathologies. The other interesting thing was that CTE was found to be equally common in people with and without clinical symptoms. So the British, who had not been amused by the American definitions of CTE, then said, let's look at our brain bank, which happens to be the largest in the world at Queen Square, and we're gonna take all the brains in our brain bank and we're gonna look for evidence of CTE. And what they found was that the prevalence in people with neurodegenerative conditions was the same as it was in controls, and there was no statistically significant difference. Patients with CTE died at a mean age of 81 years, and most positive cases were likely to be clinically asymptomatic. It was found under the microscope in equal proportions of healthy, normal, asymptomatic people as it was in people with dementia and other diseases. So clearly we have a little bit of a conundrum because we don't know exactly what hyperphosphorylated mislocalized tau does to your brain. So what does the NIH do? Well, they said, let's have another conference. So they called the second NINDS NIBIB consensus meeting to define, again, neuropathologic criteria for the diagnosis of CTE. And what they concluded was that the results of applying the McKee staging system to the cases in the consensus evaluation proved to be inconsistent. So what's going on here? CTE is clearly seen in some people who've played football, but it's also seen in other conditions, including normals. And this paper, for example, found that a combined history of head injury and alcohol or drug abuse was a significant predictor of any CTE-like changes. Age was also a significant procedure. significant predictor, most with any CTE-like changes were greater than 40 years old, and many people with CTE-like changes were not identified at sites of contusion, so they were not localized with brain injury. And what this study showed was that head trauma and alcohol were both risk factors for the presence of CTE. They could be so independently, and when they were both not present, there was a significantly less likelihood of having CTE. So here's another study. This was published in Florida around the same time by Kevin Bieniek and his group. And what they found was that CTE pathology was present in 21 out of 66 former athletes, and 3 had prior concussions. It was not seen in 198 non-athletes, of whom 33 had documented head trauma. So the headline should have been, most people with CTE are asymptomatic and it's not necessarily associated with brain injury. So that was really the take-home finding from this paper. Instead, what the newspapers reported was 1/3 of all athletes are going to have CTE. So it creates for confusing headlines if you don't actually look at the data. So ultimately, the science community then looked at this and they said, the existence of CTE as currently described is not universally accepted. CTE is not the problem. The deposition of tau may be a response to injury or opioids that is reparative or normal aging. And 71% of NFL players have abused opioids. That may actually be the cause of this phosphorylated mislocalized tau. So what they proposed was that instead of calling it CTE, we should probably refer to the clinical syndrome as traumatic encephalopathy. So now we have a new condition and it's called traumatic encephalopathy. So what does the NIH do? Well, of course, they have to define it. So the NINDS gets together and they create a diagnostic criteria for traumatic encephalopathy syndrome. And they looked at 298 cases and they developed such a criteria. And what they found was that it was present in a cohort of retired professional athletes. So the traumatic encephalopathy criteria were applied to 85 athletes. 56% of traumatic encephalopathy was observed among this cohort of retired athletes, but 54% of those meeting criteria for TES were diagnosed as cognitively normal. So again, it's not entirely clear what this correlates with. The number of games played, the number of concussions with loss of consciousness in years playing professionally were all not associated with traumatic encephalopathy diagnosis. So it's really unclear how well we understand exactly what's going on in this arena. Again, we go back to the Lily Naz-Hazrathi papers, and the conclusion that you sort of walk away with is maybe not everyone who plays contact sports is condemned to a neurodegenerative fate. Maybe the fault is in our genes. The people who have efficient repair get recovery from mild TBI. The people who have inefficient repair get cellular senescence and persistent symptoms of neurodegenerative disease. So let's go back to our original question. Does football increase your risk of dementia? Has anyone actually studied it? And it turns out that there are at least 3 well-performed published studies. This is a study performed by Rodolfo Savica at the Mayo Clinic. 438 football players followed for 50 years, and the football players had the same risk for dementia as members of the chorus, glee club, or band. Actually, the clarinet players had the highest risk for dementia. Here's another study coming out of Rochester Epidemiology Project. People who played football from 1956 to 1970 were compared to other athletes, wrestling, swimming, and basketball. Football players were more likely to have had a concussion, but they had no difference in likelihood of dementia, Parkinsonism, or ALS greater than 50 years after injury. This is the largest study that's been published. This is among men who graduated from a Wisconsin high school in 1957. 1/3 of them played football, 2/3 did not. And then at ages 54, 65, and 72, there was no difference in cognition, depression, behavior, anger, anxiety, or alcohol abuse. But the kids who played football were more likely to continue to play sports at age 35. Here's another study at the rugby, and basically 52 players, 29 controls, average age of 54 years at assessment. The controls had higher risk for cardiovascular disease, and there was no difference in the cognitive testing. So then where are we getting this idea that, playing sports is going to cause dementia, right? And why does the article about dementia feature a kid in a sports helmet, right? Number one, we've got imperfect science. Many of the papers have no controls. Normal children change as they develop, and it's very hard to hit a moving target. We've got ascertainment bias in a lot of the studies that are published, because what happens is you have an academic medical center that's studying this problem. And what they do is they put out a poster and they say, we would like to identify all the people who have, chronic effects of neurotrauma who played sports. And so the people who have the most symptoms are the ones who go to those centers. And so that creates an ascertainment bias, as all the people who are asymptomatic just stay home. The outcome measures assess the risk of brain injury, but we have no way of assessing the risk benefit of sports. So we are getting really, really much, much better than we've ever been at quantitating the impact of brain injury. Finally, we're getting there. We've got fractional anisotropy, we've got, quantitative EEG, we've got eye tracking, we've got a number of amazing measures that now tell us about whether or not someone's, had a brain injury. What we don't have is anything that measures how well a kid benefits from the psychosocial interactions of sports. So that makes the science imperfect. And then finally, we've got financial motivations. Researchers are dependent on positive results and real life application for your livelihood. So, if you've got a guy who says, well, I study hyperphosphorylated mislocalized tau, then nobody's going to fund them. But if you say, well, I study football, well, then all of a sudden there's a huge interest. And then finally, there's lots of people who want to profit from the worried well and kids playing sports. And some of the misleading headlines, they can be attributed to small studies. So here's a headline: brain changes seen in youth football players without concussion. And I just saw another headline exactly to this effect, pretty much yesterday. This is 25 boys aged 8 to 13 studied with accelerometers. They plotted the change in fractional anisotropy versus the risk-weighted cumulative exposure. So you put a sensor in the helmet, and then you give the kid, an MRI before and after. And what you find is that the kids whose accelerometers, did the most accelerating, then, they have the biggest changes in fractional anisotropy. The problem is there are no controls in the study, and there's basically one outlier that's creating significance. If you eliminate this one outlier, the line is basically flat. And then, there are other problems with the study. We have no idea what the kids were doing with their accelerometers. I asked my son what he would do with his, and he said he would, spin it around his head and throw it on the floor to see what it did. And then we don't know what the kids were doing outside of football. When you have a study this small, you have to wonder, are kids getting injured doing other activities? The kids who play football tend to be physically aggressive, not just on the football field, but on other times as well. A normal child has changes in brain structure and function as they grow and develop. So from the moment you're born, you're atrophying your neurons. You're also starting to myelinate. You stop myelinating sometime between the ages of 25 and 35. And then from there, it's basically downhill. But what this means is you're trying to hit a moving target when you're assessing brain function. And, so children learning to read activate different areas for speech as they progress. This is a child talking after they've learned how to read. And you can see that the areas for speech have moved. The problem is that the media looks at these studies and they sort of, immediately jump to conclusions. So there are a bunch of headlines. CTE found in 99% of studied brains from deceased NFL players that came out all over the media. And the problem with this study is that it was a study that had a huge ascertainment bias. Directly from the discussion section of the paper, the text read, "A major limitation is ascertainment bias. Caution must be used in interpreting the high frequency of CTE in the sample, and estimates of prevalence cannot be concluded or implied." And yet the headlines were 99%. So obviously that creates a problem. What does ascertainment bias do? It allows you to select your patient population and then make your data show whatever you like. So 93 former football players studied, and they get later life depression, apathy, executive dysfunction, and cognitive impairment. Here's the exact opposite study. 45 former football players studied, and it shows the exact opposite result. Here's another paper, 42 former football players, again, later life cognitive impairment. And then this is the exact same study, 45 retired football players, and age at first exposure does not result in an increased risk of neurocognitive deficits. So ultimately, we're left with not really knowing the answer. We've got people making decisions. They're calling for an end, for example, to tackle football, saying it's not concussions that cause CTE, it's repeated hits. Well, brain injury is not good for you. There's no question about that. Reducing brain injury is probably, in everybody's interest, but eliminating sports becomes a separate problem. And the problem is that we don't know where the risk-benefit balance lies, and it's unique for each child. So my argument would be that we shouldn't start banning things when we don't understand the complexity of function. So the classic example of something that, has sort of led to $1 billion in lost money is neurologic decline or dementia, right? It's complex. It has multiple causes, not just brain injury and pathophysiologies. And if you think that you understand it, suppose you think that, amyloid causes dementia, and there's no relationship where, a patient can have a huge amount of amyloid and not be demented, and they can have very little amyloid and still be demented. So there's a dubious connection. You're going to end up wasting money. And it's almost as if the brain injury community hasn't really learned anything from the neurodegenerative disease community. That's put huge amounts of money into targeting the amyloid hypothesis for dementia. So I would argue that when you can't accurately measure and classify a problem, don't count on being able to treat it. And this is the Biogen failed pipeline slide that basically shows all of the drugs that have failed targeting the amyloid hypothesis, and some other neurologic diseases. Interestingly, aducanumab just got approved despite not showing efficacy, at preventing dementia. And I would argue that pretty much nobody should take that med because the endpoints were proxy endpoints and not clinical endpoints. This is verubecostat. It's a failed drug. So at the end of the day, you're left with anecdote. These are all the neurosurgery department chairs who played college level football. And obviously there's a number of orthopedic department chairs that also played college level football. And in fact, neurosurgeons and orthopods were 9-fold and 28-fold more likely to have played college football than their peers. So there's a high prevalence of prior contact sports play among neurosurgery department chairs. 78% of orthopedic chairs, 86% of neurosurgery chairs, and 90% of people who study TBI allowed their own children to play contact sports, suggesting that the more one understands brain injury, the more likely they are to allow their child to play contact sports. Conversely, greater than 70% of pediatricians surveyed wanted to ban tackle football, but only 5.4% of pediatricians felt comfortable treating a child with post-concussive syndrome. So we think we understand the risk of contact sports, but do we really? And what about the benefits? Some things are easier to understand, right? Cigarettes. There's not really any benefit to cigarettes. There's risk. It's high blood pressure, vascular disease, cancer, lung disease. There's not really any benefit to brain injury. It's all downside. Seizures, headaches, motor disorders, depression, executive dysfunction, cognitive delay. But football becomes much more complex because you've got risk of brain or other injury, and then you've got benefit, right? You've got the children who are most at risk physiologically who pick this sport. So they have the highest risk reduction when it comes to things like obesity, diabetes, high blood pressure, heart disease, stroke. Obesity itself is linked to 13 different types of cancer. So if you get these kids active, that's better than not being active. And then on top of that, you've got the complex psychosocial benefit, which we're nowhere close to understanding. The children who choose to play football are not the kids who run track. Or I guess they are some of the kids who run track, but they're not all of the kids who run track. They have an average BMI of 26.3, which puts them at an 85% percentile, and they are most at risk for being overweight. If even half of those children became sedentary, so suppose you said to a kid who plays football that we're not going to have a football team next year, and they're not going to play soccer, cross country, or do other fall sports, the resultant increase in sedentary lifestyle obesity risks would be enormous. Hypertension, diabetes, cardiovascular disease, 13 cancers, osteoporosis. So, you've got you've got benefits for a population that would otherwise be sedentary and starts sports later in life. The obese child sees the greatest cardiovascular risk reduction, much more so than the lean child with aerobic interval training. The lean child, generally speaking, has more sports options than the obese child. The kids who are most likely to experience medical benefit from playing football are those who are not going to play other sports. There are very few sports that are embracing of the obese child. So my son played football. Obviously, you probably guessed that. So the whole reason that I started studying this topic is my son wanted to play football. So why did I let my son play football? So my son has asthma. He takes 2 inhalers, and this is his pulmonary function testing. And as you can see, that he's got about 2/3 the capacity of a normal child. So, he's not going to play soccer, and he's not going to play he's not going to run track or cross country. Soccer and cross country would have been his other options in that season. And, so for certain children, this may be an option that wouldn't necessarily exist if we banned contact sports. Well, the other thing that people say is, well, let the kids play tennis or maybe golf. And I put this slide in because, when I was debating this topic at the CNS meeting, Jamie Ullman was sort of famous for saying, well, why don't they just play tennis, right? And so this is a slide of the Wayzata Country Club. And, obviously membership at this club is quite expensive. And, to be honest, it's not cost effective for every child to be, trying to play other sports. Some kids can, some kids can't, but not all kids play and live in neighborhoods where there's availability for or resources for these sorts of sports. This is the membership information for the Wayzata Country Club. It's a private member-owned country club by invitation only. So ultimately, I would say sports are not one size fits all. The goal of us as physicians should be to get kids active, however we can. The focus needs to be on manipulating the risk-benefit threshold to optimize benefit. How do you do this? You follow the American Academy of Pediatrics recommendations. You follow the rules, reduce contact. So completely eliminate contact from practices. There should be no circumstance when children who are training for football hit each other. There's absolutely no reason for that. Neck strengthening has been thought to stabilize the head when impact does occur, and then tackle technique improvement. And then finally, when an injury occurs, a kid has to have proper care. Kids are going to get hurt playing all different kinds of sports. The injury rate for other sports is very high as well. It's not just football. But if you take care of the kid and you recognize the injury, then you reduce your risk for a second impact and a second injury. That's how you manipulate your risk-benefit threshold. You have to contract with the child, and this requires a culture change. So the coach-kid, athletic trainer-parent-team relationship is super critical. You can't have parents who push their kid. You can't have a coach who pushes their athlete. When an injury occurs, a kid needs to have proper care. And we have to keep the end game in mind. The goal here is a long, healthy life. It is not playing in the pros. The number of children who are going to play professional football is 0.001. It's not a high number. So the child needs to understand that they will play their best game if they're healthy. They should be incentivized to report injuries. And when an injury occurs, again, a kid should have proper care. So I'll end with sort of what do these people have in common? And, the obvious answer is, of course, they're all presidents, right? But they all played contact sports at one point. So, it's interesting that we tend to sort of be extremist in our views as physicians because we think we're doing what's best for our kids, but it's not necessarily always intuitive. I think that's my last slide, so I'll stop sharing. And are there questions?
Firstly, thank you so much, Dr. Samadani. That was very interesting. You posed some very strong arguments to specifically with contact sports and the benefits that sports in general offer our youth. What I found that was very enlightening was the particular discussion in regards to suicide and how that contrasts with those who are on a sports team. That participating in a sport, it's protective for there's a social component. They're more likely to make friends, develop leadership skills. It'll overall improve their self-esteem. What would you say that participating in sports, especially since that's on the decline, middle school age and up, whereas suicide is on the rise, that this could be a potential form of treatment for students, that maybe schools make it a part of their curriculum, are required, being a part or participating in a specific sport, or as a way to, or some type of elective as a way to encourage youth to get more involved in sports as a way for their mental health.
I completely feel that way. I feel like our goal as physicians should be every kid an athlete. And, we have to find more sports for them to participate in, not reduce the number of sports options that they have. And I think that if we have every child participating in sports at some level, they will develop better social skills. They will develop better coping skills. They'll develop more resilience. When my son used to come home from sports events and he used to say, "Mom, we lost and the referee was unfair." And I would say, this is the best training for the rest of your life, because it's what you do when you're down that matters. It's how you recover from, 36-0. It's how you get back up when the referee was unfair. Guess what? The referee's not going to be fair in life either. So this is a good opportunity for you to learn how to cope with it. And my son used to hate it because, obviously nobody wants to hear that lecture. But, he wouldn't just get it from me. He'd get it from the coaches. And that's really what made a difference. Kids don't listen to their moms as much as they listen to their coaches and their colleagues. But, that's what I think sports teaches kids, is how to cope with real life. And it's a metaphor for life. So I would totally agree that every kid should be an athlete, and preferably a team sports athlete. Not every kid needs to play football. The kids who can play tennis and golf and, other things should play those sports. But we shouldn't be eliminating sports. We should be adding to sports.
I really like that sentiment. And I also really like what you said about there are certain sports that really only fit certain kids. For example, those who are dealing with issues of obesity or maybe have a higher BMI, and that contact sports, particularly with football, is something in which they're really only capable of. But then there's another thing that I kind of want to pick your brain with, and it has to do with, and I'm not sure if you follow this story. It recently occurred about a week ago at the Euro 2020 event, where one of the soccer players in France, that he lost consciousness for 10 to 15 seconds. And so this brought this whole to light about dealing with concussions. And I believe that 24 teams then had to sign a concussion charter on that they were taking some measures to make sure that the players were safe. What are your thoughts on sports leagues and them, because of the profits that are made? Are they holding the athletes' best interests in mind? And is this something in which I know we're now moving away from youth, and it's not about winning or becoming a pro athlete. It's about, psychosocial health. But in regards to professional athletes, are they safe in that regard?
Yeah, I think there's room for improvement, and every time this happens, there has to be a discussion, and there has to be an effort made by the organizers to set a good example for youth sports. And, if what happened with the NFL several years ago is that they started taking brain injury seriously. And the beautiful spinoff of that was that every other level of sports play started taking brain injury seriously. And so I think that's going to continue. That trend will hopefully continue. The more seriously we take it, the more, we recognize that it's a problem and we treat it, the less likely we'll see chronic effects from neurotrauma. Already, I think we're seeing, when kids do get injured, there is much better recognition of the problem. Clearly, there are still, cases that are egregious, like that case that just happened that you pointed to, that need to be addressed. But I think that the trend is getting better, and hopefully it will continue to improve so that people don't play injured.
Thank you so much for all of your insight and sharing all of the research that you've very thoroughly looked through and were able to, present to us today. I would love to have you back in the future so we can talk more about this and particular topics in this way. And that was very fascinating in regards to, that takeaway about the point about youth and fact that suicide is on the rise and that athletic sports are on the decline. And I know that's not a matter of causation here, but there's definitely this correlation on it. And that's something that I think maybe we can maybe discuss in the future. And there's so many other things that I would love to talk to you about. It's 8:15 and I would love to bring you back in the future if you would be willing and available. Thank you so much for sharing your expertise.
Thank you for having me. I really appreciate it. Yep.
We look forward to seeing you in the future. As mentioned, this session is being recorded. Dr. Samadani's social media handles will be presented as well. She shared her Twitter and we'll post it as well on the website. So if you have any further questions for Dr. Samadani or would like a specific topic for her to cover in the future, please let us know and we'd love to have you back.
Thank you.
Thank you so much. Have a good evening. Assalamu alaikum.
Wa alaikum salam.